What's up, everybody? Wanted to talk about something that we'll be dealing with coming up this winter. It's influenza, also known as the flu. Let's get going. So how does influenza enter your body? Well, it's going to come through a virus, and it's a respiratory virus. But in your upper respiratory tract, so nose and throat, basically the virus, which is pictured here, enters your cell that lines the respiratory tract and is absorbed completely into the cell. We call this endocytosis. But essentially, the flu virus releases its RNA because it's a non-living entity. It needs your machinery to make more of itself. And that RNA is dumped into your nucleus where it is copied from the RNA into little proteins that will become a new virus. And that is released from the cell into your system here to reinfect a new cell. So essentially, the flu is an RNA virus. It's a non-living entity that enters your cells, hijacks your machinery, makes more replications of itself, and then is spread out to reinfect more cells in an enlarging manner. So let's talk a little bit about the different types of flu viruses that we worry about in medicine. There's two main ones. There's type A and B. To start with, type B is very slow. It doesn't change, so we don't worry about it as much. Type A mutates quickly. When it spreads from one area of the world to the other, it can be a completely different makeup of the virus, and it makes it very hard to treat. That's why there's no true effective treatments for flu. So let's talk a little bit about the virus here. So this is the virus. This is that RNA protein. It's non-living. And these two are little proteins that are on outside of this virus envelope are really important to know. So we have the hemagglutinin and the neuraminidase protein. The hemagglutinin docks on your cell, which allows the cell to allow it to enter your cell. And then once it's replicated by stealing your machinery, all this RNA, it docks on your neuraminidase cell protein, which allows it to release all this into your circulation and basically remake more protein of itself. So hemagglutinin and neuraminidase. And you'll notice when we talk about the flu, we talk about things like H1N1. Well, the H stands for hemagglutinin, and the N stands for neuraminidase. Now, there are 18 different forms of neuraminidase known and 11 hemagglutinins, although only about 3 or 4 are important of each for human infections. So essentially, to recap, the hemagglutinin protein on the virus allows it to enter your cell, and the neuraminidase protein allows it to dock to your cell after it's made more of itself to leave the cell to infect other cells. So essentially, it's stealing your machinery. Okay, so let's talk a little bit about what we need to know about influenza. The incubation is about 48 to 72 hours, meaning from the time you picked up a respiratory droplet from another human being, it will take 2 to 3 days for you to start to have symptoms. Now, you are infected, and it takes time for that to build up enough of that for you to start to develop symptoms. Essentially, every time the flu virus steals your replication and leaves your cell, it kills your cell. And so your immune system is going to respond to try to do something about it, and that's when you get symptoms. Symptoms listed here: fever, a cough, myalgia, which is just muscle pain, sore throat, nausea, rarely, but it can occur. Definitely sinus congestion because it's an upper respiratory infection. Headache, that goes along with that sinus infection. And what's interesting about the flu is it can come on very suddenly, like you feel fine and then boom, one day you're having symptoms. So, and the other thing to keep in mind, and it does help me when I'm trying to diagnose, is generally there is no diarrhea. That would be a more gastrointestinal infection, although there are cases of diarrhea in this. So our symptoms will generally last, if we're healthy, between 3 and 10 days. We're going to have fatigue. It can last from days to weeks after symptom resolution. So how does this spread? Well, this is a person-to-person respiratory transmission through droplet, which are literally spit that flies as we're talking, or aerosol, which is even finer spit. Now, aerosols can travel, so like we learned about COVID, that 6 feet rule does apply for influenza too. Now, there can be complications to influenza, especially if you're immune deficient, you have lung issues like asthma and COPD. A simple influenza can go from the upper respiratory down into the lungs, the lower respiratory, and you can develop a co-infection with strep or staph bacteria, or you can develop viral pneumonia from influenza. So the typical symptoms to know from differentiate the upper to the lower respiratory is, are we developing a cough? Well, that could still be here, not quite lower respiratory, but if it gets down in here, we're gonna have chest pain with that. We're gonna have a cough, shortness of breath, we're gonna feel winded, even just standing up. That's signs of pneumonia. We all learned from COVID, that little device that fixes your fingertip, your oxygen level is going to go down on the SpO2. We're going to have chest pain with this. When we cough, it's going to hurt. It's going to feel down here. And we're going to produce a lot of sputum, and we're going to cough this up to try to get it out of the lungs. So one thing that's interesting about influenza, there is an important sign that we learn in medical school, which is essentially you get the flu, upper respiratory, you get better, and then after a few days you backslide and you start to have lung problems. That's one of those red flag signs that you have developed influenza pneumonia from an upper respiratory issue. Now we can diagnose this. We're going to get a chest x-ray if we suspect it's in the lungs. We're going to do a procalcitonin, which is a blood marker, and of course we're going to swab the upper respiratory, nasal passageway, or blood test for flu through the PCR. Now here is a shot of lungs, and you can kind of see some consolidation here on the right lung here in the hilar area. But also look at this left lung here. This left lower lung is full of consolidation. So this looks like a pneumonia, and we would test this to differentiate what if we have viral or bacterial pneumonia or a co-infection of both. Now, the other thing that's important to know is that we're contagious one day before we start having symptoms. So we're already out there spreading it. This is why it's such a problem to control this. We are most contagious about 3 days after symptoms start, and we can spread this around for about 7 days. Some people have even been known to spread it after a few days of feeling better. So those are things to keep in mind too. We really have to be careful, especially around older people, little babies less than 2 years old, anybody who's got an immune issue, COPDers, asthma, etc. So we need to take responsibility for this. So how do we test for this in family practice? Well, there's two main tests: the rapid, which is literally a swab. It does have a high sensitivity for flu, but it's not very specific, and you can get some false positives and false negatives. It is rapid, so in family practice we'll swab, we can get a result very quickly, or if you go to the lab itself, they can get a result. The other is PCR, and as we learned in COVID, PCR is definitely more sensitive. It has a higher specificity for influenza. It can take an hour to 8 hours to get a result. There are blood tests available or the swabbing for this, so that's something to keep in mind also. This is from the CDC essentially. 1982 to 1983 through 2019, 2020 in the United States. So it's fairly current up to a few years ago. If you look at the flu season here in the US, you'll see it really peaks around February here. And so we're starting to get into flu season coming up very shortly. So that's just something to keep in mind. It helps us differentiate between the flu. Is this likely a flu if we have a patient with upper respiratory symptoms? Well, if we're in the winter, it could be the flu. There's a high likelihood of it. So we're going to help narrow down the differential diagnosis for that. So what can we do about the flu as far as pharmaceuticals go? Well, the thing is, we have Tamiflu, oseltamivir. So essentially, there's two different doses for prophylaxis. So like we have somebody that was exposed to the flu and is pregnant. Okay, that's a big deal because they're carrying a baby. We have a positive person that had the flu, a known flu. We're going to do a prophylaxis dose. It can be up to 7 days for this. The dosing doesn't change as far as the 75 milligrams once daily versus the 75 milligrams to twice daily if we have a known exposure. So the prophylaxis doses is longer, but we're doing less of it versus an actual treatment. Like we have somebody within first 48 hours of symptoms, we've swabbed or sent them for a test, a PCR, it comes back positive. We can prescribe Tamiflu 75 milligrams twice a day for 5 days and do that. There are a few other formulas of this antiviral formula where people can do IV. We used it in the hospital versus inhalation, but the typical is oral if you're able to swallow the Tamiflu. And it can be used, yes, prophylactically if there is a reason. We have an immune deficient patient that has a known exposure, a pregnant patient, known exposure. Ideally, you start this within 48 hours of exposure, or if we have a positive flu case within 48 hours, and we'll talk a little bit about why that's important. If we go back up a slide here to the neuraminidase, and so Tamiflu basically is a neuraminidase blocker. So it's already gotten into your cell with the hemagglutinin, and it's going to replicate that RNA again, but Tamiflu prevents this neuraminidase protein from docking onto your cell to exit the cell. So essentially, Tamiflu is a cell blocker, exit blocker of the RNA protein of the flu. So we're blocking it from leaving your cell. And so if we have an infection older than 48 hours, that has replicated to an extreme degree through the body and is already spread. And so we're blocking that RNA from leaving the cell is not going to be as effective. If we catch it really, really early, we can block that virus from spreading and infecting further parts of the body. So that's the explanation for that. So let's go back to what can we do besides the Tamiflu here. Well, if you're looking for natural things, make sure you're taking some vitamin D3, vitamin C. Vitamin A is helpful for a few days. Lots of water. You want to stay hydrated so that your body, your immune system can function properly. If you prefer like a nutraceutical type herbal things. Astragalus, which is a root, has a few studies out there showing that it can reduce the length of virus infections, as well as elderberry. Elderberry has a few studies out there showing it can reduce the length of cold, and there is a few small studies on flu. So those are just some of the things that we can do about this. Thank you very much.